Hi, everyone. So it looks like we're finally going to start talking about some things that will make you feel like we're talking about more nursing stuff. I know that we've been talking a little bit about the foundations of nursing, and we'll get into some more of those kind of what I like to think about as the boring topics. But since you're going to be learning this week about hygiene and looking at those things in Skills Lab, I thought we'd talk about those things here in class as well. Some of the factors that affect personal hygiene include culture. And often you'll hear people talk about how certain cultures tend to have a smell about them. And I can remember when I was early on in my nursing career, I worked with a group of residents where a lot of them were from India and Pakistan. And they definitely had a different odor about them. There were comments about them needing to take showers and using deodorant and things like that. But it had a lot to do with the types of food that they ate, which was a cultural part of who they were. Social economic class has to do with personal hygiene too. If you can't afford all of the moisturizers and fancy soaps and shampoos and things like that, when you can afford to buy them, you're going to be very sparing in their use, and you may not bathe quite as often trying to save money. And so that can affect personal hygiene as well. Some spiritual practices related to personal hygiene are things like ceremonial cleansing. We know that that exists in the Jewish culture and in some other cultures as well. The developmental level definitely is an effect as far as personal hygiene is concerned, because children are bathed by their parents, and their parents' beliefs influence the number of baths per week or per month that family may use. Teens typically are very concerned with their appearance and their smell and how they look to their peers. And so for them, they may actually over cleanse their face in trying to take care of their acne. And that actually can make it worse. With the elderly, because they're less active, they often bathe less. If they bathe more, their skin tends to be even more dry, because as we age, we produce less oils in our skins. And so they may need more emollients or lotions to keep their skin supple. Our health state also affects how much we bathe and care for ourselves. Often there's modifications that may need to be made related to whether or not we can get into a bath or into a shower. If we're not steady on our feet, we may not get into a shower, where a bath may be a better option for us. But if you have a cast or something like that, or sutures that need to be kept dry, then that may affect how you're able to bathe as well. Also, personal preferences or physician recommendations of a tub versus shower, using bar soap versus liquid soap. Those are all things that have to do with personal preferences. When we go back to the idea of tubs versus showers, often after surgeries of the genital area, people are told not to take tub baths, to only take a shower. That doesn't mean that they don't get clean in that area, but they don't want them soaking a suture line. And so, because it increases the risk of infection. Some of the interview questions that you might ask when you are admitting a patient or you're asking them about their situation is, how long have you had this problem? It's important to know whether this is something that's just come up or whether this is something that they've been dealing with for months or years even. Does it bother you? In some cases, people may have issues that it may look really gross and disgusting, but it doesn't bother them, whether it's because they've gotten used to it or it just isn't something that is a big deal in their culture. When we're talking about whether or not something bothers them, how does it bother you? Do you have pain with it? Do you have itching with it? Does it affect how you feel about yourself because of how it appears? Have you found anything helpful to relieve these symptoms? Because most of the time, people aren't just letting themselves go. They're going to try various over-the-counter type things to resolve their issues. Some of the factors to consider when we're examining skin include cleanliness, color, temperature of the skin, the turgor of the skin, which is how easily the skin is raised. So like with elderly people, you lose that subcutaneous fat, and so the turgor tends to be lower than somebody who is younger, where there's more subcutaneous fat. The moisture of the skin. Is the skin dry? Is it just normal moisture, or is it sweaty to the touch? What kind of sensation does the person have? Because in some diseases, we find that people lose their sense of touch. And so it's important to know whether that person has sense of touch all over their body, or if there are areas like the feet where they don't have this sensation that they did. We also want to look at the vascularity, and we do that by looking at capillary refill. And you'll talk more about that in class and also in your lab. Also, we want to look for lesions. And lesions are any breaks in the skin, whether it be a rash or whether it be little cuts or abrasions to the skin. Also, we want to incorporate assessment of the skin during the assessment of other body parts. So we're not necessarily wanting to, walk into a room and strip somebody naked so that you can assess their skin, but as we assess other parts, so as we're listening to breath sounds, we may have the back exposed so we can see the skin of the back. We're going to obviously have to expose people as we're assessing different parts of their body. Well, that's a time that we can assess their skin as well, so that we're not, you need to be consciously thinking that as you are doing one part of an assessment, you actually are doing a part of another as well. You want to use a good source of light, preferably daylight, because sometimes the light in a room can affect the color that you think you're seeing of the skin. So if a light has a white tone, so it may make somebody look more pale. If it has a yellow tone to it, they may look jaundiced. So it's important to be aware of those things. It's also important to be aware of what color the walls are around you. We look for neutral color walls in a hospital because if I have a blue wall next to me, I'm more likely to look a little pale and maybe even look like I have a little bit of cyanosis. Remember, cyanosis is the appearance of looking kind of blue. If I have a yellow wall, I'm more likely to look jaundiced because I'm going to have some of the reflection of the light from that wall hitting me. If the wall is pink, I might look very nice and pink and healthy when in actuality I have cyanosis because of the reflection of those colors on me. Also, we want to compare the bilateral parts for symmetry. So especially as I'm looking at the color of the skin or looking at the turgor of the skin, I want to see, does the right side look the same as the left side? Or is one side edematous and the other side is perfectly okay? And in fact, when we're looking at IV sites and we're not sure whether an IV is maybe starting to become infiltrated, we often will compare it to the other side to see if they look the same. We also want to use standard terminology to report and record the findings. If I use words that other people don't use to describe the skin, then we'll be speaking a different language and we won't be describing the same thing. We want to allow data obtained in the nursing history to direct our skin assessment. So there may be a reason why the skin assessment is the way it is. And we certainly, if somebody has a cardiac issue or a respiratory issue, might expect that the skin is not going to be as pink colored and that it's going to have more of that bluish cyanotic hue to it. We also want to identify any variables known to cause the skin problems. If I know that somebody has a history of psoriasis, that probably will explain their rashes and skin breakdown. When we assess the oral cavity, so the mouth, we're going to be looking at the lips and looking whether or not they appear dehydrated, if they're dry appearance, are they cracked, or are they intact? The buccal mucosa is the cheek area. And so we're going to look in the mouth at the cheek, and we're going to see whether the color is good, whether there's moisture there. We're going to look at the color and the surface of the gums. Do they appear to be pink? Or are they, because if they're not, it could be that the person is anemic. Or if they are cyanotic in color, it could be that the person needs oxygen. And we want to look at whether or not there's any smell from the mouth as well. And we want to look at the surface of the gums for any signs of infection. We want to look at the teeth. Do they look healthy? Is the person taking care of their mouth? Have they been to the dentist? If somebody has crowns and dental work, it shows that they've been taking care of their mouth, that they're concerned about that, versus somebody who may be missing teeth. There may be discoloration of their teeth. Those would be signs that somebody hasn't been taking care of themselves. We want to look at the tongue and find out whether the tongue is looking healthy or not. We also want to look at the color and how well the person moves it. We want to look at both the hard and the soft palates. So if you think about, like, if you run your tongue inside of your mouth, up by your front teeth, back to about the middle of your palate, it's hard. It's where there's cartilage and bony structure there. But if you go back closer to your uvula, it's soft, and that's what we call our soft palate. And so we want to look, are they intact? Are there rashes there? Are there discolorations there that might tell us that somebody has an infection? And then we want to look at the oral pharynx. Obviously, we can't get too far down the pharynx, but we're going to look at the back of the throat. And we have to be careful that we're not going to choke some or cause somebody to gag, but we want to look at that area and see if there's any growths or any abnormalities in that area. Some of the things that cause us to be at risk for skin alteration include lifestyle factors, changes in our health state. So if we're healthy and moving around and doing everything that we're supposed to be doing, then we're probably going to have fairly healthy skin. But if we have developed some type of illness or some type of disability that keeps us from moving as much, we may start seeing problems in the skin. Obviously, illness can affect our skin alterations, and sometimes the very diagnostic measures that we're doing for other things can cause abrasions, bruising, or other breaks in the skin. And then what kind of therapeutic measures are we doing? So if somebody's having a lot of pain and they wear a patch, is it possible that the rash that you're seeing on one part of their back or their chest may be caused from an allergy to either the medication or to the sticky part of their patch? And are they having itching with it? Are they having discomfort with it? And so it may be that we're seeing a very patch-shaped rash. And so we ask the patient, is this what happens every time you wear your patch? And so our therapeutic measures may cause skin alterations as well. When we look at a focus of self-care deficit diagnoses, we start looking at things like feeding. Can somebody feed themselves? So we've kind of moved away from skin right now to hygiene and the ability to care for oneself. So are these people able to feed themselves, or do they need assistance with their feedings? Or are you having to do all of their feeding for them because they are unable to feed themselves at all? When we look at self-care deficits, are they able to bathe themselves? Are they able to participate in their hygiene routines like brushing their teeth, combing their hair? Do they need assistance with those, and how much assistance do they need? The same with dressing and grooming. You know, grooming kind of goes along with the brushing teeth and combing their hair, but also, are they able to dress themselves? Can they button their buttons? Are they able to zip their zippers? Are they able to move so that they can get their arms in their shirts? Also, are they able to take care of their toileting needs? You know, maybe they're able to get to the bathroom and get their pants down, but they're not able to wipe themselves or to pull their pants back up again. Morning care for most patients involves assisting a patient with toileting, which could be as simple as just being present with them if they're unsteady on their feet, making sure that they have privacy. It could be that if they're too unstable, that you may have a commode chair by the bed to help them with that. You're going to provide comfort measures to refresh the patient to prepare for the day. So you might ask them if they want a drink of water. Can you straighten up the bed for them and the sheets so that they're not laying on wrinkles on their sheets? You might offer to provide a washcloth and some soap and water to help them wash their face and hands, and provide mouth care for them. Or provide the implements so that they can do their own mouth care. True morning care occurs after breakfast, and the nurse completes the morning care by helping them toilet themselves or assist with that. Provide oral care. So you've eaten, so now it's time to brush your teeth. Help them with bathing. Maybe give them a back massage, especially if they've been laying on their back or on their side most of the night. Having a massage will help to return the circulation to those areas. Any kind of special skin measures like putting on ointments or helping people with their hair care and cosmetics helping them to dress, whether it be in their own clothes or in a clean gown, and then helping them to get positioned for comfort, making sure that we have refreshed or changed their bed linens. It used to be that every day a patient's linens were changed and they got a bath. And now we've become more aware that some people don't take a bath every single day. I have very dry skin. If I take a bath every single day, it will exacerbate the dryness of my skin. And then it's very difficult for me to get the moisture back into my skin again. And so I would not want you to bathe me every single day. However, if I was sitting there and had a fever so that I was sweaty and stinky and I felt horrible, a bath would feel really good. And so you have to ask your patients about bathing at some times, and other times just offer to do it. And where I was taking this was that unless the linens have become soiled, we're not changing linens every day either. Because if you think about it, do you change the sheets on your bed every single day and wash your sheets every single day? Well, no. Do we need to be doing that in the hospital? Probably not. And so we've moved away from changing linens every single day. We also want to tidy up around the bedside. Last year I shared this story with the class, and I'm going to share it with you as well. It was interesting because I was team teaching this class last year, and I was team teaching this class, and my co-teacher came in kind of in the middle of the story, and she was kind of shocked by what was being said, but I'm going to share this with you. After my oldest daughter was born, I developed a urinary tract infection, actually a kidney infection. And after you have babies, you're at higher risk of developing infections. And so the doctor put me in the hospital should have been for IV antibiotics. Don't know why. He ended up giving me IM injections, which was not fun. And that's a whole nother story. But I was very ill, and I was running a fever. I was sweating. I was a new mom. I was breastfeeding my baby before I got sick. This was back in the days when people got sick, they made you stop breastfeeding. And so the milk was still coming, even though the baby wasn't there. So I had milk coming out, and I felt disgusting, and I'm sure I smelled disgusting as well. And nobody offered to help me bathe. No one brought me water. I wasn't supposed to get out of bed on my own. I wasn't supposed to, bathe or anything like that. And so I really was kind of stuck there in this stinky mess of a bed. And I felt horrible because I knew I stunk, and I felt bad. And I didn't know it was going to be my last day in the hospital, but on my last day of the hospital in the morning, the nurse's aide came in the room, and she came in and filled up a basin full of nice, warm, soapy water. And she had clean sheets, and they had not changed my sheets in 3 days. And before I could even completely figure out what had happened, this woman bathed me from head to toe. And then she helped me get out of bed and sit in the chair next to the bed so that she could change the sheets. And she handed me the washcloth, and she said, I'll let you take care of your private areas. Now, when she came in with the basin of water, I was going to say to her, if you just leave it, I can bathe myself. But I cannot tell you how wonderful it felt to be clean and to have a clean gown on, to when she was done changing the bed, to be able to slip into the bed with clean sheets on after sweating and dripping breast milk for 3 days into this other bed, this bed that had not been changed. It made me feel like a person again. You have no idea until you've gone through a situation like that, the effect of small little care will have on your patients. And I know for myself, I was in nursing school at the time. And so when I experienced that, I thought, I am never going to allow any of my patients to feel like what I just felt like. I'm going to make sure that my patient, that I act the way this nurse's aide had acted for me to make me feel better. Afternoon care, PM care, ensures that the patient is comfortable after lunch. We offer assistance with toiletry, hand washing, and oral care. We straighten up their bed linens so they're not laying on wrinkled bed linens. And we help them with mobility to reposition themselves if they're not able to do that on their own. The hour of sleep care, or HS care is what we call it, is before the patient goes to sleep at night. And so we offer assistance again with toileting, washing, and oral care. We can offer a back massage at that time. I have to say, I don't think people offer back massages as much as they should. We can change any soiled bed linens or clothing at that time and make sure that the patient is positioned in a comfortable position. We also want to ensure that the call light and any other objects the patient may require are within easy reach, because if they aren't, that patient is going to try to reach them and they have a higher risk of falling from bed. And then we do PRN care. PRNs means as needed care. During that time, we're going to offer individual hygiene measures as needed. Boy, I wish somebody had done that while I was in the hospital way back when. And change clothing and bed linens of diaphoretic patients. Oh, please do that so that your patients are not like what I was when I was admitted way back then. You're going to provide oral care every 2 hours if that's indicated. If you've got somebody who's able to drink and they're eating and things like that, they don't need oral care every 2 hours. But if you have a patient that is on a ventilator, getting oxygen, maybe just is not taking anything by mouth, then that's a patient that needs to have oral care every 2 hours. Some of the reasons for providing a back massage includes that it acts as a general body conditioner. So if your back feels good, the rest of your body feels good. It relieves muscle tension and it promotes relaxation. And it provides an opportunity for the nurse to observe skin for signs of breakdowns. Remember, most of the time people lay on their backs when they're in the hospital. So providing a back massage helps to improve circulation, and again, look for those signs of breakdowns from the pressure that's been exerted by the weight of the body. It may decrease pain, distress, and anxiety, and may improve sleep quality. It also provides a means for communication through the use of touch. Some of the purposes for bathing, which we kind of go, well, I know why we take baths. It cleanses the skin. It acts as a skin conditioner. It helps a person to relax. Think about how many times people go, oh, if I could just get in a hot tub and relax for a little while. Well, taking a bath does the same thing. It promotes circulation, and it serves as musculoskeletal exercise to get in and out and move around. It stimulates the rate and depths of respiration, so we take deeper breaths when we're bathing, which promotes comfort through muscle relaxation and skin stimulation. It provides the person with sensory input that they may not be getting in any other way, and it helps improve self-image because you're clean, and it strengthens the nurse-patient relationship. When providing a bed bath, we want to provide all the articles for bathing on the overbed table or a bedside stand and provide for privacy for the patient. We want to remove the top linens and replace with a bath blanket. And if the person wants their cosmetics, put them in a convenient place so that they can get them on their own. And also assist the patients who cannot bathe themselves completely. So you may have somebody that's able to bathe the front side of them, but they don't have the mobility to bathe their back or their lower extremities. So you would allow them to bathe the part that they can bathe on their own, and then you would bathe whatever they aren't able to reach themselves. Kind of back to looking at the oral cavity again. When we do the physical assessment of the oral cavity, we're going to observe for oral problems, for signs of dental cavities or caries. Periodontal disease is infections of the gums and other oral problems. We want to identify acute or potential oral problems that the nurses can treat and identify appropriate nursing measures for those problems. We also want to carry out the care plan. So we're going to take this assessment and then we're going to put a nursing diagnosis to it and a plan for what the goal is, and then nursing interventions to help the patient to achieve the goals, and then the evaluation of whether or not that worked. So we look at a question number 1, which is, which gum disease manifests as a marked inflammation of the gums that also involves degeneration of the dental tissue and bone? Dental caries, gingivitis, periodontitis, or plaque? Well, the answer to this is C, which is periodontitis, and we call that periodontal disease. And gingivitis and periodontitis both involve inflammation of the gums, but periodontitis also affects the dental periosteum and the bone. Dental caries is tooth decay, and that's what forms cavities. Plaque is that invisible, most of the time, destructive bacterial film that builds up in everyone's teeth that destroys the tooth enamel if it's not removed. Obviously, if you don't brush your teeth all the time, you'll actually be able to see the plaque that's there. When we're administering oral hygiene, we're going to moisten the mouth. Then we're going to clean the mouth, and if you have dentures, we're going to care for the dentures as well. With toothbrushing and flossing, we want to put the toothbrush at a 45-degree angle to the gum line in order to clean around the gums. And as far as using mouthwashes, depending on what's going on with the patient, we are probably going to be talking to the patient about whether they want to use a mouthwash or not. But in some cases, we actually use special types of mouthwashes that help to decrease the amount of bacteria in the mouth to keep the person from developing pneumonia or other infections. So we have the picture here with placing your brush at 45-degree angle looks like. Which oral problem involves an ulceration of the lips, usually caused by vitamin B complex deficiency? Stomatitis, glossitis, chilioiasis, or dry oral mucosa? And the answer is chiliosis. Chiliosis is an ulceration of the lips, which also is reddened fissures at the angles of the mouth. So in other words, at your where your upper lip and your lower lip come together. Stomatitis is an inflammation of the oral mucosa. Glossitis is an inflammation of the tongue, and Dry oral mucosa may be related to dehydration or caused by mouth breathing, altered salivation, or in some cases, medications. When we look at taking care of the eyes, one thing that we want to look at for sure is that we want to clean from the inner canthus with a warm wet cloth, cotton ball, or compress to the outer canthus. So if you look at this picture, the inner canthus is that area nearest to your nose. The outer canthus is the area out more towards your cheek or your ear. Use of artificial tear solutions or normal saline is called for if somebody does not have a blink reflex. And often people that don't have the normal blink reflex, what we put in is not so much a normal saline, but an ointment that keeps the eyes wet. We also need to make sure that we're caring for eyeglasses, contact lenses, or an artificial eye appropriately. We certainly don't want to lose somebody's glasses. Every once in a while I'll lay my glasses somewhere and I'll forget where I laid them. And I go into a panic because with my glasses not having rims, it makes it really difficult to find them. And I'm always so relieved when I find my glasses, even though my vision isn't all that bad without them. As far as ear and nose care is concerned, you're going to wash the external ear with a washcloth covered finger. Do not use cotton tip swabs. And I'll lay odds a lot of you are sticking cotton tip swabs in your ears because they get wet after a shower and then you want to clean them. But that is not safe. If something happened and you lost your balance or somebody came in and bumped up against you, you could cause perforation of your eardrum. And so we do not do that. If you can't basically what we say is you only put into an ear the size of your finger. And that means that it's not getting in your ear very far. We would perform hearing aid teaching and care if it's indicated. I have to say we probably aren't going to be doing a lot of hearing aid teaching because the audiologists are going to be doing that when they deliver the hearing aid. But we can reinforce the teaching and care of the hearing aid that the audiologist gives. We want to clean the nose by having the patient blow it. And if both nares are patent, we can assess that. We want to remove any crusted secretions around the nose by applying warm, moist compresses because we don't want to pull off their skin by pulling off these crusted secretions. When we're providing hair care, we want to identify the patient's usual hair and scalp care practices and their styling preferences. I am certain within this class that there are many that understand that there are cultural ways that go along with different races and the type of hair that they have. So the hair care that I provide to myself is not going to be the same hair care as one of you that are women of color or men of color because the hair itself is different and how the oils are distributed from the scalp is different. And so you need to follow the patient's usual practices for caring for their hair and scalp. You want to note any history of hair or scalp problems like dandruff, hair loss, or baldness, and especially like hair loss that is loss in areas that don't seem to make a lot of sense with hair loss problems. You want to treat any infestations such as pediculosis and ticks. So pediculosis is head lice. And yeah, those patients get put in isolation because we don't want head lice spreading all over the hospital. We're going to groom and shampoo the hair. We're going to care for beards and mustaches the way the person would normally care for their beard and mustache at home. Same issues, is that everybody's face requires a different way of taking care of it. And you guys that are in the class, you know that you may have special ways that you take care of your face, your beard, or your mustache if you happen to have one. Also, we want to assist with any unwanted hair removal, so we do shave people. Be very careful about this because we really are moving away from using razors in our sharp razors within the hospital because you can get nicks and things like that. And if you think about it, if somebody's on a blood thinner that's making it so that their blood is not clotting as quickly as it normally would, and you nicked them, they're going to bleed for a really long time. We are getting so that we're using more electric razors in the hospital, but they do have to be approved prior to being used so that we don't cause any shocks or fires if the person's on oxygen. We may use a protective pad or a plastic tray when shampooing hair. They actually have special hair washing trays if the person isn't able to sit up or isn't able to take a shower. Question number 3, tell whether the following statement is true or false. Pediculosis or lice can be spread directly by contact with the infested areas or indirectly through contact with clothing, bed linens, brushes, or combs. And of course, like I just mentioned, this is true. Pediculosis can be spread directly by contact with the infested areas or indirectly through contact with clothing, bed, linens, brushes, and combs. And in fact, that's how it's usually spread in schools, is that the kids share a comb, or they go, oh, I like your hat, and they put the hat of the person who had head lice on their head, and now they have head lice. And so that's a really common way for entire classes to get head lice. As far as nail and foot care is concerned, we want to assess the nails for color and shape, intactness and cleanliness, and tenderness. We want to check for a history of any kind of nail or foot problems. We soak the nails and feet and assist with cleaning and trimming nails if that's not contraindicated. I have to say here that nurses typically do not cut people's nails. This is something that is done by a podiatrist or a manicurist. These are the people that are licensed to do this, and in most hospitals, nurses are not allowed to trim nails. Sometimes we can give the implements to trim nails to the patient and they can trim their own nails, but we don't take on that responsibility because we don't want to be causing ingrown toenails or other issues or nicking them. We want to massage the feet to promote relaxation and comfort and provide diabetic foot care if it's indicated. When we look about perineal and vaginal care, so now we're getting into those sensitive areas, which in my particular case, the nurse's aide left me to provide my own perineal and vaginal care, which was perfectly fine with me because I really didn't want her down there. We want to assess for perineal or vaginal problems and related treatments and perform a physical assessment of the male and female genitalia. During that time. We want to perform perineal care in a matter-of-fact and dignified manner according to procedure. So in other words, I am not going to get all giggly or get all embarrassed or blush or anything like that when I'm doing this care. I am a professional. I'm here to provide a service, and I'm going to do the care that needs to be done. And so some of you that are younger, you may feel uneasy the first few times that you have to do perineal care, especially on somebody that's older. But when you present yourself in a professional manner, there's less embarrassment involved with this. And you can even acknowledge that to your patient. You can say, I know that this is probably not what ideal, that you would rather be able to do this for yourself. But since you're unable to do this right now, I'm going to help you by cleaning your perineal area. We want to cleanse the vaginal area with plain soap and water, and not any deodorant type soaps down there. When we do normal perineal care on women, we wipe from the top. So if somebody was laying on their back, from the top area where the urethra is down towards the rectum. I have a story that last summer when we were doing pediatrics, this little girl was coming in with repeated urinary tract infections. And nobody could figure out why she was getting them. And then one day, as they were getting her ready for discharge, they were talking about how you need to wipe from the front to the back. And the mother said, I never knew that. And apparently she never taught her little girls to wipe themselves from the front to the back. And so basically they were taking that dirty area from around the rectum and bringing it up towards their urethra. And that's why this little girl was getting urinary tract infections. And so basically once they taught her how to care for the little girl, the urinary tract infection stopped. With a male, we're going to clean the meatus first, and then the shaft of the penis. So tell whether the following statement is true or false. Monthly douching is recommended to control odor in the perineal area. True or false? The answer is false. Monthly douching is not recommended to control odor in the perineal area and may in fact be harmful since it tends to remove the normal bacterial flora from the vagina. The vagina tends to be acidic, and that is an environment where bacteria does not grow easily. And so if you are washing out this normal bacteria all the time, you will encourage abnormal bacteria to be there. And so then you'll be more prone to having infections and other things where you get the odor. So basically douching actually makes a person have more odor than it takes care of it. Also, odor is a sign of infectious processes. So instead of trying to wash the odor away, they should be going to see their doctor to find out why they are having that odor. So we have to make sure that we ensure bedside safety. We want the bed in its lowest position, and the bed position is safest for the patient. The bed controls are functioning, so we want to make sure that the bed is electrically safe as well, and that the call life is functioning and always within reach. Until we got the new building, we had some beds that we couldn't raise them and lower them. Those definitely would not have been beds that we wanted to have our patient in. In fact, those should be sent down for repair if somebody discovers that the beds are not functioning. The side rails are raised if indicated, but not the entire length of the bed. And the wheels and the caster should be locked when the patient is in the bed unless you are moving them from one spot to another. As far as patient outcome achievement, the level of patient we judge that by the level of patient participation in the hygiene program. How much are they able to do on their own in self-care? We also want to look at elimination of, reduction in, or compensation for factors interfering with independent hygiene care. So in other words, If somebody wasn't able to do it because of an injury to the arm, then we would see that the injury of the arm is no longer affecting their ability to perform their hygiene care. And then we would look for changes related to specific skin problems and independent patient management of prescribed treatment program. Our next part is about nutrition. I'm not going to spend a lot of time on this because you've taken a nutrition class, but I want to do some real basic review on this. And like I said, I may not talk as much on this one because you've already had a class. We know that there's 6 classes of nutrients, and that nutrients that supply energy include the carbohydrates, proteins, and lipids, or fats. And that we have nutrients that regulate body processes, and those are vitamins, minerals, and water is also considered to be a nutrient in regulating body processes. Some of the factors that affect basal metabolic rate, or BMR, is that males have a higher BMR related to their larger muscle mass. No matter what we do, women, even when we get really skinny, men have larger muscle mass than we do. Even the least buff guy that's around has more muscle mass than a woman does. BMR is about 1 calorie per kilo of body weight per hour for men. Basal metabolic rate for women is about 0.9 calories per kilo of body weight per hour. So that kind of explains why men are able to lose weight faster than women are. If you put when couples go on diets together, usually the man is losing weight like there's no tomorrow, and the woman is like, I don't understand, I'm doing the same things he is. Why am I not losing weight? Well, it's because our basal metabolic rates are lower. Factors that increase basal metabolic rate include growth, infections, and fever. It makes us have our body burn more calories. When we're emotionally tense, we burn more calories. When there's extreme environmental temperatures and elevations of certain hormones. Some of the factors that decrease basal metabolic rate include aging, prolonged fasting, and sleeping. So I'm sorry to tell you, women, that you'll get to an age where all the things that used to work to help you lose a few pounds that you've picked up, that little 5-pound increase over the holidays, it's going to, as you get older, it becomes harder to lose that because the basal metabolic rate decreases with aging. Also, if you have prolonged fasting, your body goes into starvation mode, and it's hanging on to all the calories it can, and it does that by decreasing the basal metabolic rate. And then, of course, when you're sleeping, you don't burn very many calories during that time. Carbohydrates are divided into sugar and starches. They're organic compounds composed of carbon, hydrogen, and oxygen. And I know you've seen the big long chains of what carbohydrates look like chemically. They serve as structural frameworks for plants, and lactose is the only animal source of carbohydrates. Humans make it for their babies, animals make it for their babies. The most abundant and least expensive, they are the most abundant and least expensive sources of calories in the world, and they're classified either as simple or complex sugars. 90% of carbohydrate intake is ingested, meaning that we end up using all of it pretty much. It's converted to glucose for transport through the blood and to provide energy for the cells. Protein is required for the formation of all body structures. It's labeled as complete, meaning high quality, or incomplete, which is low quality, based on the amino acid composition. Animal proteins are considered to be complete, and plant proteins are considered to be incomplete, although more research is showing that plant proteins are more complete than what we used to. Often they say that they need to be combined, although we were never designed to eat a combination that makes plant proteins complete like animal proteins. Plant protein tissues are in a constant state of flux, meaning that they are constantly changing, and the tissues are continuously being broken down. We call that catabolism, and then replaced. We call that anabolism. The recommended daily requirement for adults for protein is 0.8 grams of per kilo of body weight, and it should be about 10 to 35% of total calorie intake. Here in the United States, we tend to eat way more protein than what our bodies actually need. And it's definitely not something that as Americans we tend to lack. So tell whether the following statement is true or false. Red meat is an incomplete protein, and we know from that little conversation we just had that that's false because it is considered to be a complete protein. When we look at fats, they're insoluble in water and blood. They're composed of carbon, hydrogen, and oxygen, like everything else. 95% of lipids in diets are triglycerides, and they contain mixtures of saturated, which raise your cholesterol levels, and unsaturated, which lower cholesterol levels of fatty acids. Most animal fats are saturated. Most vegetable fats are unsaturated. Digestion of fats occur largely in the small intestine, and they are the most concentrated source of energy in the diet. If you remember, there's 9 grams of fat in there's 9 calories in fats. The Dietary Guidelines for Americans, which is 2015 to 2020, recommends that individuals should limit intake of saturated fats and trans fats with less than 10% of the calories per day from saturated fats, and intakes of trans fats should be as low as possible. What is the name for the product that occurs when manufacturers partially hydrogenate liquid oils? Lipids, triglycerides, cholesterol, or trans fat? So the answer to that is trans fat. Trans fat occurs when manufacturers partially liquid oils, and trans fat raises serum cholesterols. Lipids are fats in the diet. Triglycerides are the predominant form of fat in food and the major storage form of fat in the body. Cholesterol is a fat-like substance found only in animal products. As far as vitamins go, these are organic compounds that are needed by the body in small amounts. Most are active in the form of coenzymes, and they're needed for metabolism of carbohydrates, proteins, and fats. They're classified as either water-soluble or fat-soluble, and they're absorbed through the intestinal wall directly into the bloodstream. So the question with this is, which one of the following vitamins affects visual acuity in dim light, formation and maintenance of skin and mucous membranes, and immune function? Vitamin A, D, E, or K? And the answer is vitamin A. It affects visual acuity, the skin and mucous membranes, and immune function. Vitamin D provides calcium and phosphorus metabolism and stimulates calcium absorption. Vitamin E is an antioxidant that protects vitamin A. And vitamin K helps the synthesis of certain proteins necessary for blood clotting. When we look at minerals, these are organic elements that are found in all body fluids and tissues. Some function to provide structure in the body, and others regulate body processes. They're contained in the ash that remains after digestion. And that's one of those things that we sit there and we call it ash, but in other words, it's in your stool. Macro minerals include calcium, phosphorus, sulfur, sodium, chloride, potassium, and magnesium. So macro minerals means these are minerals that we need in large amounts or larger amounts. Micro minerals are things that we don't need quite as much of, and in actuality, in some cases, can actually be harmful. So they include things like iron, zinc, magnesium, chromium, copper, molybdenum, selenium, fluoride, and iodine. And when I say that they can actually be harmful, what I mean is that in large amounts of these micro minerals can be harmful to us. Like if we have too much fluoride, it's actually poisonous to us and will cause damage. Water, which we've mentioned that we're going to consider this part of nutrients, accounts for 50 to 60% of your total weight. So it's 50 to 60% of your body, and so it's very important. 2/3 of body water is contained within the cells. We call that intracellular fluid, and the remainder of body fluid is extracellular fluid, or fluid outside of the cells. These are it's like plasma or interstitial fluid in between the cells. It provides a fluid medium necessary for all the chemical reactions in the body. If we didn't have water there, our bodies would overheat in all these chemical reactions. It acts as a solvent. It aids in digestion, absorption, circulation, and excretion. And some of these things that we've talked about here and are mentioned in your book, we will be covering them in great detail when we get into patho next year. So question number 4, tell whether the following statement is true or false. Food is more vital to life than water because it provides the medium necessary for all chemical reactions and it is not stored in the body. And the answer to that is false. Water is more vital to life than food because it provides the medium necessary for all the chemical reactions, and it's not stored in the body. So we can only live minutes without air. We can only live days without water, but we can live a long time without food because of the fat stores that we have in our bodies. Some of the factors that affect food habits include physiologic and physical factors like the stage of development, state of health, and medications. So what we find, for instance, developmentally, is that young children often go into these food fads where they'll only eat chicken nuggets, or at least that's what only thing that they want to eat. And so if mom says to them, what would you like to eat? Chicken nuggets. Or teenagers will do the same thing. How about pizza? And fortunately, teenagers aren't as bad with these food fads as young children are. Our state of health may influence whether we feel like eating solid foods or would rather have liquids. And our medications can affect how we taste things. And so we may find that we avoid certain foods that don't taste good to us. When we look at physical, sociocultural, and psychosocial factors also influence our food choices. So, we've mentioned the fact that there's certain foods that are known to be a culture's foods. Italians have a lot of pasta and tomato sauces and cream sauces in other parts of Italy. I love my Mexican food, but when we talk about Hispanic food, there's a lot of variation. It's not all Mexican food. And so but what you grow up eating tends to be what you prefer to eat as you get older. Economics, culture, your religious beliefs. We had a question on the test that talked about Muslims and pork, and I've told people that have come in to talk to me about their tests about the fact that Muslims and Orthodox Jews are extremely picky about pork. and the pork even touching the food that they might possibly consume. So we have things like um, some of you that are vegetarian, if somebody brings you a salad and there's ham sitting on the side, you'll just kind of brush it off to the side. Where a Muslim and Orthodox Jew, if that ham has touched their food, they will not eat it because it's contaminated their food. And so it's very important that they not have pork brought to them when it's time to eat. When I worked for a Muslim doctor, he used to joke around and say things to me like, well, Faye, I got food that we can eat, because he knew I was vegetarian, but for him it meant that there wasn't any pork in it, even though he ate chicken and beef and other things. Tradition has a lot to do with foods. Traditionally within my family, I'm half Danish, and for special occasions, my mom would make æbleskivers, which are round, pancake-like treats that I love them, and so it's something that's a tradition for my family. Your education and politics and social status and your ideology. Ideology has to do with whether you're a carnivore, whether you're an omnivore, meaning you pretty much will eat anything, or you're vegetarian, or you're vegan, or you're a pescatarian. Those influence how people will eat when we have them in the hospital. When we look at developmental considerations, growth is very important during infancy, adolescence, pregnancy, and lactation, and so it increases the need for a good nutrition. And it also increases the calories that are needed. Activity increases your nutritional needs. Age-related changes with metabolism and body composition may actually cause somebody to eat less as they get older because they aren't as active. On the other hand, if they continue to eat on the same level as what they've been eating when they were younger, they're going to find that they gain weight. Nutritional needs tend to level off in adulthood and actually go down as adults become older. Some of the risk factors for poor nutritional status include developmental factors, those kids that will only eat the chicken nuggets and won't eat anything else, gender, some of the major food disorders are found in women, but that doesn't mean that men don't have them as well. Our state of health as a whole, if I'm not feeling healthy, I may not eat healthy. People that abuse alcohol, if they abuse alcohol, they often don't eat a balanced diet, or sometimes they don't eat at all. And so they tend to have low B vitamins, and that affects their health. Some medications, again, will cause people to not feel hungry. They may actually even make them nauseous so that they don't eat well. And mega doses of nutrient supplements can make it so that you don't eat right and may have imbalances health-wise. As far as food intake, if we have a decreased amount of food intake, it's called anorexia. You can have anorexia and not have a food disorder. It can be caused by medications like chemotherapy or some illnesses. If you think about it, when you get the flu and you're running a temperature and you just don't feel good, often you have anorexia. You don't feel like eating. When there's increased food intake, we consider that to be obesity. Not so much the intake itself, but the results of the increased food intake causes obesity when the BMI goes greater than or equal to 30. Some of the components of a nutritional assessment include history taking, looking at their dietary history, their medical history, and socioeconomic data. Physical assessments include the anthropometric, which include weight, skin fold assessments, and other clinical data. Laboratory data can look at protein status, specific vitamin status, mineral and trace element statuses. When we're doing waist circumference, which would be part of that anthropoetic assessment, we want to make sure we put that right at the umbilicus or just slightly above for measuring the waist circumference. When we look at dietary data, we ask them to do a 24-hour recall method. Often people won't remember everything they ate, and they'll say, well, I think I had this and this and this, and then like you'll be talking away and all of a sudden they'll, oh, I also had this. And so sometimes that's not the most the best way of looking at their dietary intake. We may ask them to do food diaries and calorie counts. The food diaries actually work pretty good if they keep up with them, aren't trying to remember what's already happened. And calorie counts can get to be a problem with some people. Food frequency record, how often are you eating this or that? And diet histories. Some of the factors to assess for nutritional status include dietary data, medical and socioeconomic data, anthropometric data, clinical data, and biochemical data, which we've already talked about, labs and things like that. The government has the My Plate food guide, and I wanted to kind of show you from a variation because the My Plate works fairly well for most types of diets because it's divided into vegetable, fruits, grains, and proteins. Proteins being meats or beans and other high protein foods, and then dairy. Well, if somebody's vegan, then they're not going to be following that because they aren't going to eat the meat and they're not going to have dairy. However, their food, their My Plate is not all that different. They have vegetables, they have fruits, they have whole grains, and then they choose to have legumes and nuts rather than just a general protein group. And then they're going to drink water instead of dairy. As far as nursing interventions related to nutrition, we want to teach nutritional information, monitor nutritional status, and do things that are going to stimulate the appetite. If you are laying in a hospital bed and you're stinky, you're not going to feel like eating. If you feel disgusting, you're not going to feel like eating. And so we try to do things to make the environment clean and that everything, you don't want somebody's urinal container up on the bedside stand next to their tray that they're going to eat out of. That is not appetizing. We want to assist with eating if they're unable to feed themselves. And provide for oral nutrition. If people are not able to take everything by mouth, they may need to have total parenteral nutrition or partial parenteral nutrition where they have an IV fluids that have proteins, fats, and vitamins and minerals in them. That's the far extreme. They may need to have an NG tube put down and have their feedings given through an NG tube if they aren't able to take things orally. We consider an NG to be short-term nutritional support, and we confirm putting an NG tube in by X-ray. That is the gold standard. And we measure how much is sticking out from the nose as a way of verifying that it is still in place. We aspirate and check the pH. and we can do a visual assessment of the aspirate, showing that it looks like the food that we put down or the curdled food that we put down. And like I said, we measure the tube length and the tube markings to make sure that it's where we left it. We can do carbon dioxide monitoring, and this is how we confirmed a nasal intestinal tube placement. If we're looking at long-term nutritional support, they may need to have a gastrostomy tube placed percutaneously. And you can see in the top left picture, it shows how it goes through the wall of the abdomen and into the stomach and is held in place by a balloon that keeps it from slipping out. The enterostomal tube, it can be placed through creating an opening into the stomach or in the jejunum. And a gastrostomy is the preferred route to deliver enteral nutrition in a person who's comatose. So if we have somebody who's comatose, they're probably going to have a G-tube in. The placement of the tube can be accomplished by a surgeon or gastroenterologist, either by doing a percutaneous endoscopic gastrostomy, which is known as a PEG, or surgically, and with that they actually open or laparoscopically place the gastrostomy tube in the correct position. In some cases, as in the middle picture, it may actually have a long tube that sticks out where you connect the feeding tube that's like a IV tubing, but not. Feeding tubing and IV tubings are different in their size, so that you can't accidentally connect feedings to an IV site or put IV fluids into a feeding site. The picture over on the side is it's also a type of PEG tube, and we call them a button, a G button, that opens up. Actually, you kind of screw the feeding into it, or in some cases they sort of have a top on them that opens up, and then you attach the feeding into the end. Parenteral nutrition means it's IV. It provides calories. It restores the nitrogen balance because it has amino acids in it. It replaces essential fluids, and it replaces vitamins, minerals, electrolytes, and trace elements. It can be given through a peripheral IV or a central line. It is given on a pump, not on a drip, because we don't want people to just get a really fast bolus. That means a big amount all of in a short period of time, and so it's always given on a pump. Sometimes they put medications into the parenteral nutrition solution. Usually they have to do with when people have reflux or they have ulcers. So it may be things like ranitidine or other things to decrease the acid in the stomach. Some of the complications that are associated with TPN include insertion problems of the IV sites or the central lines. Infection is a major concern because since it has fats and proteins and everything, it's a perfect medium for bacteria to grow in. And so we worry about infection and potentially sepsis since it's going directly into the bloodstream. There can be metabolic alterations, and so electrolytes are followed very carefully on patients that have TPN, and there can be fluid and electrolyte and acid-base imbalances. Again, we follow those very closely. If the vein becomes inflamed, the patient can develop phlebitis. If they get too much lipids, they can develop hyperlipidemia, which basically means high lipid in the blood. Also because of the way the liver and the gallbladder are involved in the breaking down of these fluids, they can develop liver and gallbladder disease. And that completes this lecture, and I'll see you guys in class.